welcome to this week's edition of Managed Care TV. I'm Steve Thornley, CEO of carenational, and I am excited today because I have a special guest here in my office that I've known for 10 years at least or more, and that's Jenn Sommers. And Jenn, tell us a little bit about yourself and your background, and our topic today, of course, is value-based care initiatives from CMS. So where do you come from in this whole healthcare scene?
Well, first and foremost, thank you for having me.
You're welcome.
As Steve mentioned, I'm Jenn Sommers. I've been here in Arizona working exclusively in healthcare for the past 20 plus years.
Yeah, we'll just stop at 20.
We'll stop at 20. Yeah, because I was thinking you and I have known each other for over 18 years, if you can believe that.
Oh, that's right.
Yes,
yeah, okay.
I can't even believe it. We can stick with 10. It makes it seamless.
Keep it even. There you go.
So I've been here in Arizona working in healthcare. I started my career at Intergroup of Arizona back in the day. It was a small, homegrown health maintenance organization.
Was that in Tucson?
It was.
Okay.
It was.
It became part of
It is now HealthNet,
HealthNet,
yes.
right.
Yeah, it went through a few different iterations before it's landed on HealthNet. But I ultimately was the provider relations manager for Intergroup of Arizona for a few years. I spent over 10 years within the organization. Have also worked on the provider side at both SonoriQuest and Insight Diagnostics, dealing with revenue services and...
Which is really where I first officially met you, right?
Yes, SonoriQuest. Yeah, yes.
Way back in the day.
Way back in the day. And then I also spent some time helping and supporting organizations from a temporary labor perspective, and that's, I think, some other times that we spent
we connected,
doing staffing.
Absolutely.
Doing staffing initiatives, which was wonderful. It was great having an opportunity to be able to work on being able to help the next generation of folks coming into healthcare, those folks that may not have experiences or backgrounds understanding healthcare, because certainly we have that needed in our workforce.
Sure.
And then for the past 10 years, I've been at Mercy Care Plan in Mercy, Maricopa. I am currently assigned to a grant that we received from CMS back in 2015. It was one of CMS's largest grants that they've ever put out into the community. And so it's
Can you tell us the amount of the grant?
Well, we've received $14 million over 4 years.
That's awesome.
Yes, so it's wonderful. So it's specifically focused on transforming clinical practice initiative. It's called TCPI, and it's really focused to be able to help the provider community be best prepared to take on value-based contracts and being able to work in an environment where they can use their electronic health record systems and all the tools and technologies that traditionally have not been fully optimized in healthcare. I think pretty much any other organization or any other type of industry is very accustomed to using electronic tools, and I think healthcare is just getting up to that point in the past 5 to 10 years where electronic health records and information being shared on the Health Information Exchange is something that's new to most folks. So
yeah, I'm particularly excited about that as a consumer, because I went to an urgent care not long ago, and I was pleased to know that information I can continue to log in, and everything hopefully is syncing together.
Yeah.
So so that's fantastic. And talking about your role, so I know you introduced yourself in a provider capacity. So what have you done up to this point with the providers? What has been your main focus point?
Yes, so within the TCPI grant itself, we are a practice transformation network. We committed to partnering with over 2,500 clinicians here in Arizona to be able to help them with being more educated and working toward the different activities that need to occur to be best situated to deal with value-based contracts. So what we are doing is actually focusing on helping with educational efforts. So we coordinate with national organizations to be able to help do educational sessions with individual practices as well as groups to be able to help them understand how to use electronic tools and resources. The Health Information Exchange, as you described it in your personal situation, what's wonderful is that folks that enroll with the Health Information Exchange are able to from a clinical perspective, share information across practices. So in your perfect example that you shared, going to urgent care, your primary care physician, when you go in to see he or she in the future, would be able to actually access that information if it was shared by the urgent care to them.
Okay.
And as well, if they are connected with the Health Information Exchange, they can go out there and get information. So if you had blood work done or an x-ray done, rather than having to order those tests and have potential duplication of testing, they can just go seek that information and pull it down from the Health Information Exchange.
Right, because that's what you used to have to do before, is like you'd go take a test and then your primary care doctor would have that, but then maybe you'd refer you to a specialist, and the specialist might want to do their own testing.
Right.
So there can be some crossover, which is really costly.
Oh, it's very costly. It's one of the biggest initiatives under TCPI is the reduction of unnecessary testing. So one of the things that's wonderful about the initiative itself is it gives an opportunity to educate organizations and practices on how to prevent unnecessary testing in our environment. So in healthcare, as you mentioned, there's opportunities for duplicate testing and unnecessary, that those can be extremely costly, up to the millions of dollars. In instances that we have actually seen, there have been cases where people have received 4 or 5 different X-rays, or not X-rays, but MRIs, and those MRIs can be upwards of $400 or $500 each. And not to mention you're radiating someone. But that's just due to duplicate testing because they didn't necessarily know to go out and seek the information that was already available. So say, for instance, you went into the urgent care and they ordered an MRI for you. You go back to your primary care. They don't realize the urgent care's ordered one. They order another one. And again, we've seen examples of that where there's upwards of 5 or 6 different MRIs done, exact same MRI, like on your lower back, done 5 or 6 times for an individual. So that's just a lot of unnecessary radiation, just due to lack of information being available.
So how are providers adapting to that, to releasing now their records into the hub, or whatever you want to call it, to the exchange?
To the exchange
itself. Are they jumping on that bandwagon pretty quickly without resistance? Or
Well, so fortunately in Arizona there have been initiatives in place for the past probably 8 to 10 years with getting practices up to speed and getting involved with the Health Information Exchange. Some of that does require having applicable electronic health record systems updated to be able to share that information. So some of it was due to system limitations that it wasn't previously changed. But now most systems have now made it so that they can share that information, and it's a specific file format that they need to be able to share. And then ultimately it's a matter of those practices setting up workflows to have the right level of personnel going in and capturing that information. We certainly don't want clinicians sitting behind a computer screen all day trying to capture information off of an electronic health exchange.
But they got to care for patients.
They do, which is one of the reasons, again, going back to getting the right level of staff doing the services that need to be done. We've really worked with some practices to develop workflows where their front desk personnel, as part of what they do with verifying a person's eligibility and other things as they're preparing for the day's visits, have them also embed in that workflow an opportunity to go out and retrieve information from the Health Information Exchange. So it's there for the clinician when they actually come into the practice. So Steve's following up with the primary care after a visit. The front desk person, when they confirm your appointment, actually goes out, retrieves information, and puts it in the electronic health record system so that when your physician sees you, you can sit down and your physician would be able to say, Steve, I saw that you were just at urgent care. Here's what it looks like happened and occurred. Let's talk about what the next steps would be and that type of thing.
It just seems that in America, like with all of our technological advances, like why did this take so long?
Well, I think in general, healthcare has definitely been behind this, as you've known. You've been in healthcare for
the times.
Yes. I always use this example with folks. The technology is there and has been there. I just think there have been so many reasons why people have had apprehensions about sharing it, whether that's for the traditional HIPAA concerns of don't sharing personal or don't share clinical information, PHI and all of that. But certainly when you can go into any other industry and be able to, at the drop of a hat or a click of a button, obtain information and full histories of information, it's about time that the healthcare environment gets up to speed with that.
Adapts to that. Well, cool. Well, I've got tons more questions for you, but we are going to take a quick break. And we'll be right back with Jenn Sommers and talking about value-based care initiatives. Be right back.
At CareNational, we are experts at recruiting medical coders for a variety of positions within reimbursement management and managed care. Our services include direct hire placement, temporary staffing, and project staffing. Each medical coder we place is screened to your company's exact specifications, including verification of coding or medical record certification by a HEMA or AAPC, employment and education verification, background for criminal or fraudulent activity. Additionally, we offer a guarantee giving you additional peace of mind for your investment in a qualified coder. Call CareNational today to find a custom solution to your staffing needs. We can be reached at 1-800-974-4828 on our website at carenational.com or simply email coders@carenational.com.
Okay, so we're back talking to Jenn Sommers, and lots of good things. One of the questions I wanted to use as kind of a catalyst to keep the conversation going is, so you've got this grant, and it's $14 million, and you have 3 years?
We have 4 years in total. It ends September of 19.
Okay. So what's the bird's eye view plan for deployment, and tell us the mechanics of that and how that's going to work with your providers?
Sure. So for the first year, we were really focused on the recruitment of the clinicians. So we had committed to 2,500 clinicians, which we have. So we have a few of our practices that we've worked with that are actually getting to the point where they're ready to graduate. So the initiative itself basically looks to have 5 phases of transformation that occur. And those phases really start with setting an aim and setting a goal of what the practice wants to accomplish. Much of this was directly aligned with the MIPS and MACRA kind of legislation that came out. But what we found here in Arizona is that we are so saturated with ACOs and other organizations that have Medicare shared savings programs in place already that really our focus ended up being more with behavioral health providers. We are part of a large pediatric clinically integrated network, which is Phoenix Children's Care Network. We work with a quality health network as well as other behavioral health organizations. So for us, what we are trying to do is make sure that what we're working with the practices on is to be maturing in the activities that need to occur to be prepared for value-based. So what TCPI has set forth there are 5 phases of transformation that occur. And within those phases, the physician and the clinical staff as well as the administrative staff are looked to be able to make sure that they have basic processes in place. So the examples that we were talking about with urgent care and use of the HIE, some of the things that are very basic are things such as, do you have your membership loaded into your electronic health record system? You would be amazed. Step one, do you have the individuals loaded in your system? Again, EHR systems have been around for some time, but they've not been fully optimized. So we definitely have practices that we work with currently that do not have all their membership in their system loaded. So for many health plans, they assign populations to primary care clinicians, and those primary cares are responsible to work with the population on preventive health screening and other different activities, up to and including keeping them from utilizing high dollar like emergency room visits and having inpatient stays when they're not really medically indicated. So we really look to the primary care to have that relationship with the population that they're responsible for. Clearly, it would make the most sense that the population needs to actually be in your system in order to make sure that you're doing appropriate outreach. One of the things that we work with the practices on is to make sure that they're aware and understand who their high-risk population is. So if you're in a situation where you have a primary care practice that focuses on internal medicine and they have a high population of their membership that are actually diabetics, if they don't have that population loaded into their EHR with applicable information housed in the system, they would have no opportunity to run reports and kind of do proactive outreach to those folks to make sure that they're getting continuous kind of communication about the importance of getting your blood tests taken, having your your feet evaluated, and other things that are important with diabetic populations. So we really work with those practices to make sure that they have just some of the basics accounted for. So we do a series of assessments with the practices to make sure that we ask them specific questions about how their infrastructure is set up and the workflows that they have in place. And what happens is we get results back from those assessments that give us kind of the measurement for how well a practice is doing. There are instances where a practice may feel like they have a lot of activities that go on to address their population, but then when you ask them basic questions such as, do you have a process to receive electronic health information related to laboratory testing? Is that electronically loaded into your system, and do you receive reports on those folks that may have test results that are outside of the normal range? Many of them kind of look at us like, oh, no, not at all. Like, I don't know. I didn't know that that was an option. So we are able to work with those practices to make sure that they are fully optimizing their electronic health record system. Most of those systems have processes set up in them to be able to have triggers for that type of reporting to occur. You just have to know to have it actually structured to actually do that.
So this is real unique because in my world, you know, I've recruited a lot of case managers for hospitals and for insurance companies. So what we're talking about here, I mean, usually the only time I hear from my doctor is like, hey, we're calling you with a test result. Now they're actually going to take a more case management approach, proactive approach to following up with people, which I think is great. Why did it take so long for that type of idea to come into play if it's done for discharged hospital patients?
Right. So. And that's a perfect example. Again, I think that there are things that you would think are kind of the norm. Another great example is following up with folks after they've left an inpatient stay. So again, as part of the health information exchange information that's shared, they can actually subscribe for alerts and notifications from the HIE that will let them know Steve was just in the hospital this weekend, or Steve just was in the emergency room last night. They can actually receive those alerts real time and be able to take action and call you and say, hey, just found out that you were in the emergency room or that you were in the hospital, where they may have otherwise not known it. I think, again, so much of it just comes back to we haven't had those processes and workflows structured in the healthcare environment. I think in general we've been more of a respond to a situation versus proactive. For many years, there have been activities that have been in place to address quality measures. And again, that's where MIPS and MACRA come into play, like selecting specific quality measures. But one of the things that TCPI is intended to do is help those practices be able to look at how they can improve on those measures. So again, I think stratifying your population that you have, how many of your folks are adult, I'm going to keep on picking on you. How many of you're just easy at this point, but how many of your population are adult males that need to come in for colorectal screening?
Done that.
Yes, so those are the types of things that a lot of the practices are starting to get there. But those are obviously high risk factors that we would want to be able to address if you haven't had a step or processes in place to identify your population that need to have those tests done. Because again, as you mentioned, most men in general are in situations where they don't go to the doctor unless there's a reason. There's something acutely going on.
Something macho about that,
right.
Ego is what it is, I think. Just kind of going back for a second on the whole follow-up. I mean, what's the common thing the hospitalist says when they discharge you? Follow up with your PCP, right?
Yes.
So now if they're going to get an alert, then that's going to maybe kick it. Hey, wouldn't it be nice if the doctor's office was calling you to set up that follow-up appointment? Yeah.
Yeah, so and here in Arizona, we actually also received another grant from CMS that's related to targeted investments, and it's really focused on not only on the perspective of physical health activities, but behavioral health activities. So where you have folks that might be having both a behavioral and a physical situation going on, there are specific activities that now Access has received additional dollars to be able to infuse out into the system to get the community to also take additional actions on that population that might have a comorbid.
People that have multiple diagnoses, right? The people that are dealing with comorbidities.
So they have comorbidities is exactly what I was looking for. So, but what's happening with the targeted investment program itself, very similar to TCPI, it's intended to be able to set up processes to be able to help, and what I call it is just really help with the maturity of healthcare providers becoming more adept to using the tools and technologies that are out there. So things such as identifying who your high-risk population is, targeted investment here in Arizona, those dollars that have been set forth folks out in the community actually applied to be providers to receive those additional dollars. So that just recently started into the Arizona market, and there are practices that have now said, we do want to be more involved. We do want to make sure that we have processes in place to identify high-risk populations and then have activities going on that are able to make sure that there is additional steps taken, such as follow-up after being discharged from the hospital, or looking at a situation where you may be looking at a person who is got a very depressive state, but they also have diabetes, and their diabetes it's not controlled.
Sure.
So again, you have an opportunity to look at what those test results are and make sure that there's outreach to the population who may be having a more acute situation going on that's not just based on their behavioral health condition.
Sure.
So,
and working with the Medicaid population, how much do you see that crossover between having somebody having comorbidities and also have a behavioral health piece? I would imagine it's larger than maybe a commercial plan would be dealing with.
That's an interesting point. I don't know from a comparison whether or not the statistics would show that there is more in our population that, and I call, the Medicare and Medicaid population in general,
sure.
Depends on who you talk to. Some will tell you that they're much more costly than those folks that are in the commercial side or that are actually paying additional dollars towards their healthcare services. But we definitely see that from a proportion, I would say it's somewhere in the 20% range of the population that we deal with that are actually receiving services that have both physical and behavioral health situations going on. With the onset and with the continual growth of kiddos with autism spectrum and other things
right.
that are going on, there's definitely more and more of what we're seeing going on from a younger age
sure.
than just those that have traditionally been looked at.
Because autism, for example, 15 years ago was very rare that those people were being diagnosed, right? Diagnosis is much more grand these days. Well, I got two other really burning questions, but we're going to take one more break and be back right after this with Jenn Sommers. Talking with Jenn Sommers, and we want to talk about integration. Is that what we're kind of going with this new process that you've been talking about with the Transforming Clinical Practice Initiative?
Yes.
So it's pretty lengthy, so we'll just call it TCPI for short.
So TCPI, again, is very focused on making sure that all folks that are involved within the healthcare system, including the front desk folks, the medical assistants, nurse practitioners, and physician assistants, as well as the actual clinical team, are very much involved in having activities in place that will help with streamlining the way that we provide healthcare in our country. So I think in general, making sure that, again, the clinician isn't the one that's going out trying to search for information on the Health Information Exchange. It's a coordinated effort between the different levels of folks that are within the practice. So one of the things that we work on is just making sure that when we look at a workflow that goes on within a practice, that we've actually been able to sit down and actually see of those activities occurring. Things such as verifying eligibility, which is a very important thing for practices to do, is still something that is pretty much dealt with in the old school fashion.
Right.
There's ways to do it electronically now. There's ways to set up batch files to be able to do validations and that type of thing. So we really try to make sure that when we're working with a practice, we're able to identify all of the workflows that they have in place and really see how that connection to the EHR is occurring. I think it's one of the things that will be continuing to be an area for improvement over the next few years. And certainly as more and more information is readily available to be shared electronically, there's going to be more of a drive for everyone involved to be actively participating.
Okay, awesome. Talk about the patient-centered medical home portion of this, because I know for me, I've made my wife vow, and I'm going to talk right into the camera, vow that she would never put me in a nursing home because I want to be at home. But talk about that side of it for a minute with your program.
And sure. So one of the things that we are really focused on is making sure that, again, individuals throughout the spectrum, whether they're a Medicare recipient, the traditional kind of aged adult that is receiving services under CMS, all the way down to children that may have special needs or disabilities that cause them to have added challenges. We really want to make sure that we're working with organizations so that we have the right wraparound services for all individuals.
Sure.
So if there is a situation where there is a person who is more high risk and that have opportunities for us to be able to deal with things proactively to prevent hospitalization or a situation where they're having to be in a situation where they're residing in an assisted care living or that type of environment that they don't want to be.
Right.
So we work on programs with those practices to be able to identify risk factors. One of the things that we've worked on recently is collaborating with A.T. Still University to be able to help them go out to practices and do education on programs that are addressing fall prevention. So if you were a situation that you're aging and you are a potential at risk, there are things that we're working on with those practices to, again, have the dialogue with the individual to look at what the risk factors are to try to mitigate those. So again, sometimes that includes doing an assessment of the person's home. That includes being in a situation where you're looking at what types of medications that are being given to the individual that may require additional kind of oversight and management. Certainly not having a good pharmacy review is a problem that we work on with practices as well. But in the instances that we try to work on with those programs, we go out to a practice and talk to them about the opportunities to do the evaluations and then be able to help with taking action on what could happen within the home. So situations such as making sure that, if a chair is not appropriately structured for an individual to be sitting in, getting up and walking around, that they look at what alternatives can be there, whether that is, again, just adjusting the chair, taking out the rug, different things that could potentially be fall hazards. And that type of stuff is something that's really important for us to be able to take out. That's outside of a traditional visit with a clinician. In general, a clinician's not going to say, so what's your home life like? Like, what are the things that could be problematic for you?
But are the clinicians starting to come into the home more and more?
There's different programs in place. I would say your clinicians, from a primary care practice perspective, are not kind of transitioning to that. But there are more and more services available within the community that allow for it.
Okay. Because I think that's the important part is like it's great that maybe a nurse comes in and does wound care or they bring in their DME or whatever. But, I've heard of some models emerging where they're, the traditional house call of the olden days is actually coming back in under that model.
Right. And some of it may not require an actual clinician visit. So to that point, someone may be discharged to home that has an IV therapy need. A clinician may not necessarily need to be the one, but it could be, it could be another level person that's able to go. And again, as part of that review, one of the things that we work on is to make sure that anyone that is working with that individual is also doing a basic assessment within the home to say, is there something else that's going on that could be problematic? In the case of, we'll use a child example too, if there are instances where there are problems going on with an asthmatic child, sometimes there's not full disclosure about, well, we have 3 cats at home, or we have an environment that might be causing those asthma exacerbations to happen. So those are the types of things that we really try to work with all of the organizations to be asking those questions. And that's without even getting into the social determinants of health that we could spend all day talking about. But
but if there's if it's somebody that has 16 cats in their home, that might be a contributing factor for some of their health issues, which should motivate the insurer to get out and do those home visits. If that's the goal, is to help them heal at home. So getting a little bit off topic, but I want to get your take on we've heard through the news that the president is looking to potentially cut Medicaid, and we just expanded Medicaid in Arizona under Governor Brewer. So what's your take on that from your vantage point? Obviously, it will be hurtful if that is changed, but do you find your members being apprehensive about about healthcare reform still, or what's your sense on that?
I think that there's still such a wide array of conversations that go on about healthcare, and really, I think more often than not, I hear from folks that don't realize that they're eligible to receive access. I think, as you mentioned, Arizona has expanded. They had the Medicaid expansion. We've had the Medicaid expansion. And so we're in a situation where we actually have very broad coverage. I do think that there are some concerns if there were to be a reduction in what that coverage entails. However, I do think that part of what we're really focusing on as a community is trying to make sure that we're using all of our resources appropriately. So those are educational programs. I know through Mercy Care Plan, one of the things that we've been spending a lot of time on over the past few years is helping to educate the communities about community gardens and about healthy lifestyles and activities. Those are things that aren't necessarily paid for through Medicaid to begin with, although those community activities are things that are really important to help people with recognizing the importance of taking good care of yourself and eating good fruits and vegetables and exercising and doing other programs, stopping smoking and those types of things. So I do think that even though there is the potential for there to be changes in the future with how the program is in place, that we have a real kind of learned behavior in Arizona about wellness is not just about healthcare alone. That looking at all those other contributing factors and things that could influence keeping people healthy and, again, being able to drive down some of those expenses so that we are in a position to still be able to cover as much as we can with any limitations that may be presented.
Sure. And, like my first guest on the program, Dr. Luke, emphasized becoming an engaged healthcare consumer. Are you seeing that more with some of the membership, or, because of some of these new programs and initiatives? Are they taking charge of their healthcare versus just having it be a reactionary situation? Like,
now I'm sick. Yeah, well, one of the main pillars of what goes on with TCPI is having patient and family-centered care. So that is a primary driver to being able to make sure that practices are working with individuals on having those conversations and communications about why it's important to get adequate sleep and exercise and not smoke and those types of things. So I do think that by way of some of the programs that are coming out, that the value is being driven to quality, not necessarily how many members did you see, but how the quality of that visit went, and were you able to make sure to address all of the contributing factors of their health care, of their health status, I should say. I think that that's definitely something that's what CMS is driving from a national perspective. And I do think that because we have more of an aged population that are continuing to age, we really want to focus on how do we keep them the healthiest possible, as well as dealing with the kiddos that are coming in with more and more various ailments. We're trying to say, how do we make sure that we keep them as healthy as possible and prevent unnecessary services, whether that's testing or emergency room visits and that type of thing.
Okay. I mean, we could be here all day, and I could ask you tons of questions, but we simply don't have the time. I really appreciate you coming out, and can we please have you back at some future point as you're implementing this quality initiative with Mercy Care? That would be great to see how that results. And I always like to end on a positive note. Of all the things that are said about healthcare and all the things we hear in the news, there's some really exciting things happening. Wouldn't you agree?
I would totally agree.
I mean, more so than in the last 10 years.
Yeah. Well, to know that this particular initiative, that one of the key indications of what CMS wants us to do is to bring joy back into the practice. I mean, that's a key. The fact that CMS wants clinicians and practices to have joy is something that does say that they recognize that unless all of us are working together and feeling like that we are actively having an influence on the future.
Well, if those clinicians are more engaged and proactive, it seems like it would take the robotics out of it, like I'm going in, I go to work today, I'm going to take care of patient A and then patient B and then all through the list. It just seems like it's going to help people to really enjoy their career more.
Absolutely.
When they can see the impact that they have by taking that proactive approach. So, well, wonderful. Well, thanks again for stopping by.
Absolutely.
And a couple of quick announcements before we sign off from the broadcast. March 16th, we have a special Managed Care TV broadcast. We're going to be talking to Dale Bellis, who is the Executive Director of Liberty Health Share. And Liberty Health Share is a new type of healthcare payment plan where you share the costs So it's not insurance, it's an alternative for health insurance, and so we're really excited to talk to him. That'll be the 16th at, are we doing it at 8 Pacific, RJ? Is it 8 or 9? 10. We're doing it at 10 Pacific. Okay, so 10 Pacific on March 16th. Make sure to tune in for that. And of course, if you have any ideas for our show, or you would like to have some specific subjects or guests appear, please email me. My email is steve@carenational.com. And again, we appreciate Jenn Sommers being on the show, and we'll look forward to seeing you on the next Managed Care TV broadcast. Thank you.